Thank you, everyone. Appreciate it. I'll try to get us on time here for our lunch break. So I'm going to talk a little bit, really this is focused on calcific Fem-Pop disease, and I'm just going to focus on two therapies in particular that are on the horizon. These are my disclosures. So, we've seen this really nicely in this case and throughout the conversations so far in this wonderful Congress. These are the challenges we're dealt with frequently with calcium. And I think, again, we underappreciate the consequence in particular of scaffolding without good vessel prep, as well as really the idea of vessel recoil. A lot of times we can get some luminal gain and then we don't pay attention to what happens, 10, 15 minutes later. And so we really need to focus on adequate vessel prep up front with the right therapies to get long-term results. So I'm going to kind of cover these two devices because I just had a fragment of time. I want to make a comment. Right now, there's a plethora of lithotripsy devices that are either on the market or coming to market. Some of these are in trial right now, but these are the two that are going to be most relevant to our practices for the rest of this year. Seismic being the new player, which is the laser-based lithotripsy device by Boston Scientific, acquired from Bolt. And then Shockwave, I'm going to focus a little bit on the newer E8 device that has made a big impact in my personal clinical practice. So just focusing on Shockwave first, everybody's familiar with this technology. This has been presented throughout this Congress. I just want to remind you that a 2-atmosphere balloon with IVL therapy gets you 50 atmospheres of pressure. So, you saw Chris bring a Dorado balloon down there at high pressure. This is going to quadruple what a Dorado balloon could apply when effectively used and sized. Remind yourselves that we always size up with lithotripsy. You have to get good approximation to the vessel wall. So we go 1.1 to 1. So everything is oversized by 10%. And on top of it, any air in the bubble will create challenges with delivering therapy. So we want to make sure that it is degassed. But when used appropriately, sized appropriately, you can see in these micro CT scans the fractures, some of which are visible on intravascular imaging. Some of them are not visible, but show you with their balloon expansion that they've made significant benefit for that vessel prep. Now, right now, Shockwave's come out. You just saw Anvar just talk about a little bit of the Javelin in his case. We kind of got two new lines kind of simultaneously. First was E8, which is an extension line for the infrainguinal or M5 plus and S catheters. And then we also have the Javelin, which I won't speak too much on right now, but it's another good strategy for balloon uncrossable lesions. To remind you, for the E8, the big benefits for this device versus what we had been using as a predicate device is longer balloon catheter. So this is now an 80 millimeter balloon catheter. We've been asking for longer treatment devices for a while. The other nice part of this is get 400 pulses in total. So it's 4 paired emitters. So you're getting significantly effective long balloon lengths with good rounds of therapy delivered faster than before, again, like the M5 plus, 2 hertz per second. Again, I just will remind you that we only need 2 to 4 atmospheres to get you 50 atmosphere of treatment. So again, you do not need to overextend this balloon just to make an improvement in plaque mobility. This is kind of how the sequential channels work. So again, it's 4 paired emitters, so 8 emitters in total across the balloon catheter, and you can see it pulses in sequence. So you get kind of boom, 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 boom. So each of these are being pulsed. Now you can't control the emitters; they are firing at their own pace. But the goal here is again to get active, fast therapy to the balloon lesion, and you get 10 cycles in total for this single balloon catheter. And for me, again, having an 80 millimeter balloon, I'm sure most of you feel the same way. It's much more relevant for the infrainguinal space. We don't get really short lesions anymore. The other thing is sometimes you get healthy tissue between calcific lesions. IVL therapy is it's not harmful to a normal vessel. So again, these sonic waveforms will go right through the vessel wall as long as calcium's not there. So you don't necessarily have to be worried about treating areas that you may not want to stent or definitively treat after this. You can treat those healthy segments in between without much trauma to the vessel. So real quick case, just to, again, keep us on pace. 75-year-old patient came in with life-limiting claudication. We're very aggressive about medical therapy. After more than 6 months of treatment, including an exercise program, we brought him to the lab for treatment. Here's the intervention. You can see on the SFA here, there's a short occlusion. You can start to see the collateral show really nicely, and I kind of froze that frame for you on the right. And then you can see on the rest of his runoff just diffuse subtotal calcific disease, again with, let's see if we can get this to play, with kind of squirrely collaterals recanalizing that vessel. So I thought this was a great one, and usually what I would do for this is wire. I'd balloon with an undersized balloon and then deliver IVL therapy. Again, IVL is on an 014 platform, so you have to make sure you're ready to go to an 014 wire. Everybody knows my affinity for IVUS, and that's usually part of this program. But for the new device, I thought it would be nice to see, as it's now coded, I didn't mention this, but the 80 millimeter E8 is coded and much more deliverable, how it worked traversing a occlusive disease. So here's me, and I'm going to show you my target zones. Here's me wiring this lesion with cross-lead wire. I then use a crossing catheter just to, let's see if I get these to play, get these to demonstrate that I'm luminal across that occlusion. And then I use that crossing catheter to switch out for an 014 wire that I can then use to deliver the shockwave device. I really like this cross lead. I don't know if anybody's used the cross lead wire before. Really nicely J's through occlusions. You can see nicely how I can push through that CTO without really much pressure and made our case much quicker. So here's now the E8, and I don't have it crossing, but I did no vessel prep, and the E8 flew through that occlusion, and then I was able to treat up and down that segment with a single balloon catheter and get good result here. So this is unexciting to watch an IVL balloon inflate, but just showing you nicely that with some rounds of therapy, we're able to get good expansion throughout that CTO. And then just with IVL alone, we were able to restore good flow. Again, you can see decreased amount of use of those collaterals, nice demonstration of a recanalized vessel. I'm very aggressive about vessel prep, so we saw that nicely in Chris's case beforehand. I went back in with a 6 millimeter Serenator balloon. I DCB everything, and I left it with just a DCB result. So again, I thought this was a good example of being able to really effectively improve the flow of care with a newer IVL technology. Again, crossing a CTO, we didn't use any other balloons outside of the IVL balloon and the Serenator, and then the DCB for definitive treatment. Just before I run out of time, there is a session on this during the meeting specifically focused on seismic. Seismic is the rename of the bolt catheter, and the idea is seismic, kind of like tectonic plates or earthquakes, and then IQ is kind of the intelligent portion of a laser-based treatment. And this is different than shockwave. This is not electrical energy. This is laser-based energy. So you can see nicely in these images on the left, there's this what they call a plasma plume, which is what an interesting way to describe it. But that laser-based plume creates this cavitation bubble. So in theory, it's the same idea of generating these cavitation bubbles to crack calcium safely, but it's done now with laser-based technology. And you can see really nicely on the right here, these canisters, these kind of ceramic canisters that are being popped off with this technology. And this is what Shockwave used to do on the benchtop. Really amazed all of us that this can work so seamlessly. The idea of laser therapy, and again, this is coming to a limited release market soon and will be available. It's FDA approved now, is that in theory, these devices can be more deliverable. They can deliver more energy. They can provide more rounds of therapy. And then on top of that, the emitters themselves can be controlled. So you can turn emitters on and off if you want to target specific lesions and not necessarily hit other areas. So I think that on-off part also is going to be a nice way to customize treatment. We're going to learn more. The one challenge with seismic right now is that it was approved based on data that was generated in Europe. All great data, and Marianne Brahman's here who did a lot of those studies, and I know stands behind this therapy, but we still have to gain some US experience. So I'll just briefly show you the Restore ATK results, which was the Fem-Pop data, but as part of an ongoing Boston Scientific Registry called Elegance, there's going to be more data collected on this therapy so that we can be up here on podium next year looking at some US-based data showing benefits with this treatment. Just to end this talk, I just want to really highlight this one slide showing Marianne and Restore ATK's data. Zeller presented this at Viva last year. 95 patients with femoral popliteal artery disease, greater than 70% stenosed with moderate to severe calcification. And you can see nicely that 100% of people had a residual diameter stenosis of less than 50%. There was no perforation, distal embolization, or dissection that was not expected. And so this is really where IVL therapy shines, is the low risk of all those complications we've seen with other plaque-modifying devices. I'm going to yield the microphone now to lunch, but thank you very much for the opportunity to be here.